Good morning. My name's Anne. I'm the substance misuse specialist nurse based in the Wirral. Today I'm going to talk a little bit about stigma and how it affects patients uh, who we need to access service to. So I'm just going to cover the extent of alcohol use in our society and focus on the financial costs. I'm going to talk about problematic drinking. What is stigma? What's stigma theory and what's stigmatizing language? How stigma influences decisions on accessing services and how to lessen the impact of stigma that has on alcohol using patients. Alcohol has an impact on every aspect of our social life, both social, economic and cultural. And most people drink socially with no particular problems. There is a small proportion of people that drinking will become problematic. So much so that it's one of the biggest factors for ill health and death among 14 and 49-year-olds in the UK, and the fifth biggest risk factor across all age groups. There are almost 1.3 million estimated admissions to hospital a year that are directly related to alcohol, or alcohol as an impact on whatever they've been, their initial diagnosis. Interesting to note that alcohol prices have increased by 28% in the last 10 years, but they're still more affordable than they were in 1987. This is because of the difference in prices at that time, and also sort of based on what incomes were, what income people had. So the public health data reports the total cost of alcohol is around 3 billion a year. The total cost of society as a whole could be as much as 55.1 billion. This was a piece of research done by the National Social Marketing Centre in 2006-07. It wasn't published until 2017. And this included things like lost productivity due to absenteeism, and which had a knock-on. Sorry, I'm going to start that. Public Health England reported that the total cost of alcohol to the NHS was around 3.5 billion a year, and the total cost to society as a whole could be as much as 55.1 billion. This was a piece of research done by the National Social Marketing Centre in 2006-2007, and things that they included were lost productivity due to absenteeism, with additional funding to cover workloads, accidents, violence, including domestic violence and crime. Also, increased things like border control, educational stuff to try and address these issues, as well as the cost of care. How much alcohol indicates a problem? Well, according to the UK government, up to 14 units of alcohol spread over a week is considered to be a low risk level. This is for both men and women. At one stage, men were allowed 21 units, but recently they've decided that it doesn't matter what your gender is, the impact will be similar. When we talk about binge drinking, this applies to 6 units or more of alcohol for a woman and in a single session, and 8 units for a man. And this was documented in the NHS in 2020. If the level of alcohol consumption exceeds 14 units of alcohol for a woman, or is less than 35 units, this is labelled hazardous drinking and increased risk drinking. For a man, hazardous drinking would be over 14 units, but less than 50 units a week. Harmful drinking, high risk drinking, is considered weekly alcohol consumption of over 50 units for a man and 35 for a woman. So there's a great difference between low risk and high risk. There are alcohol dependence is defined more than its level of consumption, and several factors influence this. A strong desire to drink despite negative consequences, and a reduction in usual activities spent spent drinking instead. Also, the development of physical withdrawal symptom when alcohol is used to manage symptoms of withdrawal, and several more cognitive, behavioural and psychological factors. An example of this is when people talk very much about they need to give up drinking for family, for children, for parents, but still continue to drink. The desire to drink overrides all of those factors. Stigma. Um, there's a chap called Irving Goffman who writes an awful lot about stigma, and he said he discusses the idea of stigma and what it's like to be a stigmatized person. Goffman looks at the world of people considered normal in society. Stigmatized people are those that are not accepted socially and are constantly striving to adjust their social identities. This could be with physical deformity, mental health, drug addicts, and sex workers. What do we mean by stigma? Stigma can be defined as a mark of disgrace associated with a particular circumstance or quality of person. That's defined in the Oxford languages. Stigma versus stigmata. Although physical signs are important, we are more interested in influences of stigma on physical treatment updates. For a nurse working on a gastroenterology ward, those physical symptoms are liver flap, spider nevi, ascites, that type of thing. Within this presentation, the emphasis is on the stigmatising of the person that may impede their uptake of services and healthcare. Societal views of dependent drinkers. Most people talk about time wasters taking up a bed, self-inflicted illness. They never learn. There's repeated admissions, often known as the revolving door. And they feel worthless or less important than sick people. Exposure to stereotypes and the application to self of stereotypical characteristics means accessing treatment. If you feel as though you're stealing somebody else's bed, if you feel as though it's in self-inflicted, so you're not valued, so need care. This can cause a barrier for people. They constantly self-discharge. They don't engage in what's being offered to them from the health perspective, and this is all about self-worth. Harmond in 28 states internalising stigma may be a barrier to accepting treatment, so it makes it harder for them to actually access service. And in a recent conference on drug-related deaths, it said stigma kills because it silences people. People then won't ask for help. Stigma is a phenomenon either perceived Stigma is a phenomenon either is perceived as personal or public. The public stigma includes the perception of attitudes or behaviours towards the problematic alcohol use and the belief that characteristics applied to the particular user applies to all. That means that the general feeling of the public is if you drink too much, then you are going to be a time waster. You're going to have repeated admissions into a bed that you don't deserve, and that the general stigma of you're not as important within society. Personal stigma is internalised by the individual and refers to the individual's own attitude of alcohol use and alcohol users. And that can be something that, if a nurse has personal experience of what's gone on, has somebody in their family who's caused, problems and worries for themselves, will quite often internalise that stigma, and it will be applied to anybody that they then are there to. So stigmatizing language. We hear words all the time like binge drinkers, alcoholic, ex-user, which means it never goes away. Ex-alcoholic, street drinker, revolving door patient. And one that we hear an awful lot within our hospital is your patients. We've got one of your patients in the hospital. That is very stigmatizing. They're all our patients. And when somebody stopped drinking and is be pulled back to that ex-alcoholic can sometimes be a barrier to people actually moving forward with their lives. Some of the ways that we can change stigma is equity in care. All patients should be treated the same. All patients should be treated with compassion. We should avoid stigmatising language, both verbally and written in records. I've seen things in records that says another boozer. It's not a medical term. Don't know how it would be called, but this is things that we have certain services that we use on a regular basis. That if we give a leaflet and tick a box, then that's our job done. If the patient's not at the centre of their care, then they're less likely to access that care. And we should listen to the patient about how they feel their addiction should be managed. They should always be given a chance to utilise what they feel are their strengths to address this issue. And include family in treatment with permission of the patient. Quite often families come in and have one view of what's going on, patients have another. Usually there's an implication that if somebody's got an addiction that they're always going to be lying to you. So their take on things might be particularly different from the family. So if they want family involved, it should be with the patient's permission. Avoid being prescribed with services and tailor care to the individual, with them at the centre of what's going on. Give information that they can use in future if they feel they need some more support. If they don't want the services you're offering now, try and get them to take a leaflet, just saying, just in case, if it doesn't work, if you feel that you need more information, then these people will be able to help you. And there's always the local GP. So it's not about this is the end. It's about making sure that they've got tools to go forward with. For me, another way of managing it is alcohol screening and identification should be embedded into the admission assessment that approaches all patients to avoid the need to be singled out. So if everybody's asked exactly the same questions, it becomes a normal. It doesn't feel as though you are only being asked these questions because of past history or what's going on for you. I'd like to see more formal education regarding substance misuse for all healthcare workers, and particularly for student nurses. We, in our hospital, quite often get student nurses that come out and about with us, and they're quite naive about what substance misuse is about, and what is available within the community. So it'd be really good if that was included in the nurse training. More research regarding barriers to accessing healthcare for substance misuse is an absolute must. The uptake of care in the community is very poor. We need to do more about the doorstep, so we need to do more about us initially talking to people about what services there are out there, but then actually engaging them into those services once they leave the hospital. Hospital is a very safe place. You can make choices there, you can make decisions there. But once you're back in your own home with the same situation, the same pressures, and the same routines, then relapse is very easy. And we need to challenge the perception that accessing treatments means you've reached rock bottom. We should really proactively looking at early access to help. So this approach is about talking to people on their first admission, using things like brief intervention, and trying to stop some people becoming those dependent. The idea of stigma begs the question of whether it's inevitable. We all have stigmas. We all views. Should we therefore accept it? Or are there ways we can reframe the ideas we held about certain groups of people in general and with alcohol users in particular? That's not seeing them as time wasters, trying to interact very proactively with them. It's acknowledged that when people come into hospital and are intoxicated, they usually have challenging behaviours. They're quite difficult to manage. when they've got liver disease and actually end up on a gastroenterology ward, you have a lot more time to engage these people, make sure that they do have access to alcohol workers, and that their ongoing care is planned exactly the same way as you would regarding a physical problem. Any questions? Thank you.
Welcome everybody for attending this lunchtime afternoon session. I'd like to introduce Anne, who you've just seen her presentation. I've known Anne for many years, and if you do have any questions for her, please put them in the chat and I'll ask them directly to her for the time being. But whilst we're waiting for any questions, Anne, can you tell me more about what kind of deprivation and stigma you see within the Wirral? Because I do know that Liverpool, compared to many other cities, does have a high amount of deprivation.
Yeah, we have real areas of complete deprivation. We also have the absolute other end of the scale where we have extreme wealth. So there's an area called the North End of Birkenhead, which has probably the worst deprivation in the country, and it's like 500 metres away from Millionaires Row. So it's a bit of an enigma on the Wirral. We also have an awful lot of alcohol-related admissions to hospital. I think we're about third or fourth in the league table. I know that Glasgow's above us and Bolton is, and I think maybe Blackpool, and then along comes us. We're a very, very small peninsula. We're only about 13 miles long and I think it's about 10 miles wide. We have over 1.1% of the total drug use in the whole of the UK. As saying, we're fairly close to the top of the league table from alcohol. So our admissions to hospital are huge.
Now, there's a question in the chat which is very similar to what I would have asked you anyway. We all inadvertently stigmatise patients with our terminology, and I think it's historical. How can we get around this, the use of or misuse of words like alcoholic or drug user? How can we get around that?
I think by normalising stuff, we've as a substance misuse team have actually looked at the language we use, and some of that is stigmatising. And we said at the end of the presentation, do we just accept that there's certain words that can be seen as a stigma, and try and reframe our responses to this? My favourite is always your patients, and my response is there are patients. We have a really good gastro team within the Wirral who show great compassion for our client group. A lot of them are disenfranchised from everybody. They don't have family attachments anymore, and our gastro team, particularly the nurses, if there's a patient that's a regular with them who is in the last days of life, they'll go and get them from another ward and make sure that they are with nurses that they know at the end of the days, because they don't have anybody else. And we see great compassion like that. So you can also almost excuse some of the language that they say inadvertently. It's not meant maliciously or viciously, but it's very hard for somebody who's got an addiction to be in a bed when they're hearing, you don't deserve it. It's for somebody who's really sick. People think that addiction is just about the substance, and the substance to me is always a symptom. It's never a cause. It's complex and complicated. And I just think by allowing these people to feel valued, it's more likely that we're going to be able to engage them into treatment. The doorstep from the hospital to the drug treatment services is huge. They're full of hope for a new beginning when they're in hospital. But it's an alien situation for people. It's not how we live our life. Once we're back into the community and we're doing exactly the same as we've done previously, it's so easy to fall back into stuff. Our community service is quite good, that once we've referred them, they will actively chase them. So they'll send letters, telephone calls, they send outreach workers out if necessary. So we do try and sort of reduce that doorstep, but making people feel better about yourself. I use the word worthless because quite often that's what they feel, that they are. They're worthless. So you have to sort of try and instill some sense of of worth into people for them to engage in what's going on. Our situation on the Wirral is, occasionally dire, and we do lose an awful lot of patients.
So I know me and you have both presented together around the UK. For me, the teachable moment is key. How can you improve the teachable moment for anyone who's involved in, whether it's liver disease, because we both worked in liver disease as well, or drug and alcohol services, for those people who turn up at the A&E front door or acute medicine or even on the gastro units?
For me, it's got to be brief intervention all the way. And not foisting your ideas on people, allowing them to make the decisions about how they're going to help. Quite often we keep people or come in and say, no, I can manage myself, support my family, or I'll be able to do it on my own. I don't want to feel this pain again. And when they get outside there, it's going to be so difficult. So we sort of try and encourage them. Yeah, that's really good. Let's see what your plan is. Do a lot of brief intervention initiatives, and then we'll try and make them encourage them to take information about other services. We also say, whatever we can give you as substance misuse in here, GP can refer you to the same services outside. So give them options if it doesn't work. And the other thing is treating them with respect when they come back in, because quite often, and I have seen it happen, and I understand the reasons for it, that a repeat offender, eyes roll, are you again, this type of thing. And I absolutely get that it's frustrating to see the same patients come back again and again and again. But if you start off on that foot, you're never, ever going to get anywhere with them. It's about making sure that you're truly engaged with them and you're listening to what they say. Early intervention is the most successful treatment. Once you've got a patient who is embroiled within an addiction, particularly with alcohol, it's so much harder. You're looking for very small movements in general health, then you're not looking at anywhere that would be seen as a cure. That's early intervention. So for me, that's the most important.
There's a question coming from the chat, and actually it's come from Kate, who unfortunately couldn't get onto the screen with us. She's got a very good question, I think, and the question is, do you have clean injection packs for those who attend the hospital with injecting drug use? No, unfortunately, it's never been able. We tried to introduce naloxone kits as well, but there's so many hoops to jump through that it became impossible to actually do them. But our local community team, we have information around syringe exchanges in our local pharmacies, and most definitely, if people need injected information or equipment, we have outreach workers that will go and make sure that they engage with them once they've left the hospital. But it is a bit difficult. We still we work in an acute medical hospital who quite often don't understand the harm reduction method or much about substance misuse. So the patients are seen as my patients. Yeah. I know we've got about 2 minutes left. I just want to add something to that, and there's a very good question in the chat. So let me just add my bit. I did a presentation in America last year, end of last year. Harm minimization for the Americans is very different. They don't see it. They see it as, why are you helping someone, as you rightly said, who's trying to hurt themselves? Yeah. And for us, needle exchange and these packs that you're advocating and Kate's advocating, we know saves lives. It saves more lives than many other interventions out there, and it's relatively cheap. So the last question I had for you is in the chat, and it's a good question, which unfortunately Kate would have been able to answer as well, is, do you have any tips on how to communicate with patients that have high alcohol intake and also have comorbidities without making them feel stigmatized?
That could be either dual addiction or, the old favourites like COPD, hepatitis, liver disease. It's harm. For me, harm minimization is the harm that you can reduce on the day. If you try and give them too much, they'll back off from you. Absolutely. So it can be very small movements, constantly relaying the similar messages, making sure that people have access to services when they're out in the community. And I say we're a very small community, which is one, in our favour. So we have one community drug service team, so they tend to know everybody that's around, whereas if you're in a big city, they can get lost between the different services. So fortunate in that way, but for me it's small messages, speaking to people like they're human beings, engaging with them and finding out more about them than just their drug use. I've been fortunate to be in this for a long time and know my clients over decades, so it's so much easier that way.
Yeah, and I agree with you. It's normalising the language, because if someone had COPD and was still smoking, you would have those conversations about why you're still smoking 10 a day. Why would you consider bringing it down to 5, or smoking cessation? And Kate's right. She's put something else in the chat, which is which is good. There's many people out there who don't know about units, and I think that should be our core language.
Yeah.
But I think, thank you, Kate, and for chipping in on this, because it's been a really good 10 minutes with regards to talk about, I think, the darker side of healthcare, which shouldn't actually be the dark side of healthcare. It's just normal. It's out there, and we should address it properly. So thank you very much for your time, and thank you, Kate, for chipping in the chat.